Good afternoon, everyone. My name is Hussein Tahan, and I will be facilitating this session on unseen diversity. It is a pleasure to be joined with two experts, and together we will address diversity, equity, and inclusion, concepts we often refer to as DEI. I will start with a brief description of what DEI is, highlight its importance, and share a few practical strategies how to promote DEI. Dr. Margaret Moss will present on a real-life example concerning the American Indian communities. And Dr. Vincent Guilamo-Ramos will then talk about issues of health disparity. Afterwards, we will open up the session for a dialogue with you, the participants. Allow me first to briefly describe what diversity, equity, and inclusion mean. To me, these are ethical principles we must all demonstrate in our actions, interactions, the decisions we make, whether on a personal or professional level. Diversity is respecting and embracing the unique characteristics of every person or group. It is appreciating, protecting, and celebrating what differentiates them from one another. Equity is the fair, just, and impartial treatment of others. It is about how one exercises and advances the human rights principles toward others and toward oneself. Equity is grounded in distributive justice and the reasonable allocation of wealth, power, privilege, and resources to all social groups and individuals. From a healthcare perspective, equity is the absence of systematic health disparities. Inclusion is the act of welcoming, acceptance, and empowerment of everyone within a community, group, or structure, such as an organization of employment, regardless of circumstance or status. It is also the degree to which an individual feels welcomed by others to act authentically and contribute to society in a meaningful and deliberate manner. Diverse and inclusive organizations make bolder and innovative decisions. They deliberately anticipate consumer needs and forecast market shifts. They are successful in promoting openness. They proactively manage the concerns of bias and discrimination by fostering a sense of authentic belonging when that supports and celebrates the various aspects of diversity. These types of organizations maintain a competitive advantage in their market share as well as in the industry at large. They achieve such stature because they apply a strategic and systematic approach to DEI. In these organizations, DEI is reflected everywhere, in the mission and vision statements, in their strategic plans, in their objectives and strategic initiatives, and in the composition of their professional teams and workforce at all levels. It is also evident in leadership accountability, where the performance of leaders is evaluated using key DEI-related outcomes. Diverse and inclusive organizations outperform their industry peers in many aspects of the business imperatives, including profitability. For example, in a recent study reported in May 2020 by McKinsey and Company, it was found that organizations in the top quartile of diversity were more likely to experience above average profitability than those in the fourth quartile. Let's share a couple outcomes that are reflective of the impact of diversity on profitability. Organizations with top quartile gender diversity experience 25% more profitability. Those with top quartile ethnic diversity experienced 36% more profitability. And those with more than 30% women on their executive teams were found to have 48% better financial performance. It is therefore important for all of us to really focus on DEI and make every effort to improve in those respects. It is important to know, however, that not all diversity characteristics are visible. In fact, some are invisible, and all of the aspects of diversity are equally and uniquely important. The aspects are endless. Just take a moment and notice the over 20 characteristics I share with you on this slide. Just take a moment and reflect. Which one have you been blinded to? What can you do differently to notice such characteristic of diversity? How can you use it to improve a personal or professional relationship or a key outcome of a project you are working on? We must take the time to notice these unique determinants of diversity. We must recognize them, accept them, acknowledge them, appreciate them, nurture them, and celebrate them. To enhance DEI in our personal and professional lives and the communities we serve, we must promote openness and acceptance of every human and social being. We must treat everyone equally and equitably. We also must deliberately nurture their belonging in our communities and our lives and the organization where they work. We can do this by exploring and understanding our unique differences in a safe, empowering, and accepting environment, whether in a society at large or our workplace. We must respect the different attitudes, beliefs, social determinants, literacy levels, and priorities of the various client populations we serve as healthcare professionals. We must do this regardless of the health-seeking behaviors these individuals exhibit when they are in our care. Most importantly, however, we must shift the disempowering practices, whether in the workplace environment or in our interpersonal relationships. For example, instead of discrimination and bias, let us deliberately embody acceptance. Instead of isolation, let us affect a sense of belonging, and instead of microaggression, let us practice empathy with one another and in everything we do. At this time, I would like to turn over to Dr. Moss so she can begin to address DEI in the American Indian community.
Thank you so much. I would like to start with a short land acknowledgement. I'm speaking to you today from the unceded traditional and ancestral territories of the Hunkaminam-speaking Musqueam people in Vancouver, British Columbia, coming from my own nation, which is the 3 affiliated tribes of North Dakota, the Mandan, Hidatsa, and Arikara. So I'd like to start now. I often begin with a very rudimentary Indian 101 as I speak across the country. I've been a nurse for 31 years, an academic for 20, and I still ask these questions as I go along. Do you know how many federally recognized tribes there are in the US? This is a question that I ask often, and I rarely get the correct answer, which today is 574 federally recognized tribes. Most people are familiar with Navajo, perhaps Sioux, as they say, or Cherokee, but they don't realize that there are almost 600 federally recognized tribes. And the next question, which is, do you know how many state recognized tribes there are? And it's about 66. It depends on how you count them, because some are both federally recognized and state recognized, and some are state recognized alone. And the next question is, do you know what each of these means? What is a federally recognized tribe? What is a state recognized tribe? And why is this important for a nurse or any healthcare professional to know? And the answer is that there's a government-to-government relationship with federally recognized tribes. Congress decides who is a federally recognized tribes, and therefore who receives certain healthcare supports, such as the ability to go to Indian health services, which are still around the country, mostly in the west of the Mississippi, to receive health care that has already been paid for through ceded lands and agreements and so forth. State recognized people would have to go to their own states for any American Indian programs put up for them, also including Alaska Native. So it's important to know, if you're a nurse taking care of an American Indian or Alaska Native, to know what is their political status. These are actually political statuses. And then understanding where you could send them, refer them, and so forth. And next question. Do you know who is an American Indian or Alaska Native? So we're talking about invisibility, and this is something that comes up quite a bit. And there's two different answers. There's one in the eyes of the US, and there's one from the American Indian community themselves. So in the eyes of the US, you are only an American Indian or Alaska Native if you are an enrolled member of one of these federally recognized tribes. Those are the people who are in the nations that have a government-to-government relationship. So if you're to be checking boxes for a federally recognized tribe, you need to be a member of one of those tribes. And there's in legal terms, you're only an Indian if Congress says you're an Indian. It's actually if you're only a tribe, if they say you're a tribe, but the tribe says whether then you're a member. Also important for nurses to know so that they can drive them to a specific services that are available. People might not recognize that. The next question, please. And misidentification is a top problem. Talk about invisibility of American Indians. Do you know who's in your care? How could you possibly say that you're giving culturally competent care to your group, whatever group that is, whether it's in the hospital, primary care, nurse practitioner, and so forth, if you don't really know who's under your care? So misidentification, there's a Trends in Indian Health, which is a report that comes out of the Indian Health Services every few years. I think it's been 5 or 6 since the last one. I believe I counted at one time, there's 137 asterisks saying we don't really have the great answers on this because identification is off. The minute they go out of Indian Health Services into the states, identification is off. So I can tell you myself, I have been counted as white, Hispanic, Native. Nobody ever asks. People are afraid to ask. So they just guess or they say nothing. Death counts are off by 40% according to one report, because again, it's the ME or the funeral director who's just looking at the person and deciding what their race is. So therefore, cancer registries are off, death counts are off, access, all sorts of things are off. Just we can't even get past the identification phase. I think in that same report, the next closest group was only off by 4% in terms of identifying race. And so American Indians are way off the chart. So I do tell my nurses in the various schools I've been in to ask. All you have to do is ask. Now the person could say, I don't care to identify, but at least ask. That's something that nurses can do, anybody in intake, to at least start to get real numbers about these things. And what I tell them is, I think it's since the 1990 census that now 78% of American Indians are off reservation. So you're going to start seeing, you probably have in your practices, wherever they are, American Indians, yet you haven't noted, you haven't identified this, so you don't know what their problems are specific to that group. Health problems, socioeconomic problems, social and structural determinants of health. You won't know because you don't even know who's in front of you. So I'm trying to ring that bell, identify, or ask them, and that's something we can do. I think there might be another one on this slide. So in the Future of Nursing report, I noted, I was actually a Robert Wood Johnson Health Policy Fellow during these years, 2008 and 9, rolling into 10. And American Indians were not very mentioned. I think they were mentioned twice just in terms of percentage of how many there were as nurses, and almost nothing else. I saw one talk of, moving, one example of moving nursing to an entry point of BSN, to start to think of ADN, try to move people, which sounds good in theory. However, for the American Indian workforce, they did show the one example of North Dakota. North Dakota was the first and only for a long time of BSN only entry. What this did was constructively cut out American Indians in that state for becoming RNs, because they mostly came from the tribal colleges, which were 2-year colleges. So there are all these problems. Nobody saw it. Nobody's thinking about it. That's the best case scenario. But that invisibility continues. So the next slide. Sorry, there might be one more. So then how do we increase that population into the nursing, healthcare, and workforce? And I think I'm talking about this actually on the next slide, if we can, oh, sorry. So where do we go for almost starting from zero? In that people are not identifying who these patients are. The nurses are not actually in the workforce. So in my most recent work, there is so much going on about indigenizing the curriculum. At least possibly have a mandatory course in the health sciences, or start integrating ideas of indigenous context, health, outcomes, anything into the curricula. So what brought me to publishing this book called American Indian Health and Nursing, a textbook, came out about 5 years ago, was because I myself went through 3 programs. I went through, the initial to get your license, a master's, PhD, never once had any mention of American Indians till I got to PhD, and I just crafted my own curricula for my own program. So just to have something, when I went to the publisher, they said, oh, surely there's something out there. They looked for 2 weeks and said, there's nothing out there. I said, correct, there's nothing out there. So if there wasn't even a textbook, there's very few, there might be a couple of mandatory courses now, but in 50 states, it's pretty nil. So we need to start indigenizing the curricula, and I mean from K through 12, even through to the health professions, because there isn't much there. You get the turkey at Thanksgiving when you're little, and Christopher Columbus and so forth, and not much else. So we can go to the next point. So the second thing to do simultaneously is to decolonize, which means there's only this one perspective. Up here in Canada, they talk about two-eyed seeing, perspectives coming from 2 different places, 2 different populations. And this is one of my examples. I went to an academy plenary a few years back, and I noticed on the screen was, incidence of prostate cancer or something to that effect. And of course, African-American males had the worst, and then there's, the white, non-Hispanic, Hispanic, and so forth. And American Indian were barely mentioned at the bottom, like, oh, there's no problem there. Well, there's no problem because they're dead. This is a disease of older men. And just as an example, on my reservation, Fort Berthold in North Dakota, the life expectancy for a male born today is about 52. So they don't even get this far. So that was a point of missed conversation. The life expectancies are low. And even though they have half the incidence, they're at 87% for mortality as compared to others. So there's so many ways that invisibility continues. And I was lucky they were on the charts. I go to so many meetings where there's 5,000 papers offered, and American Indians don't even hit the charts. They are invisible in conferences, just absolutely invisible. There might be about 5 student papers who did a qualitative, they talked to 5 elders. Nobody is including them. There has been a study in education, or a paper written up called Beyond the Asterisk. Same thing happens in education, that, oh, by the way, American Indians, they're just an asterisk. So these 2 things need to happen. Then the next point, last point on this slide, is to move towards reconciliation. So in this text, I did address the future of nursing in American Indians. So if we're wondering why aren't there more nurses to take care of this, everybody wants concordance in provider and patient care. Well, just to throw out a couple of facts, and then we can move to the last one, is that American Indian women, for instance, are murdered at 10 times the rate of the next closest group. This is on reservations, and it has to do with laws that are still on the books about non-Indians coming onto a reservation and doing things and then leaving, and they're rarely caught, rarely prosecuted. If they are caught, and rarely held for any amount of time, it's known as open season on American Indian women. So if something like this is happening, how many people even know that that's happening, and it's been happening for a long time? How are we getting young American Indian women who are reservation-based or in some tough urban situations to be thinking about, chemistry and geography and hypotenuse and whatnot when they're just trying to make it to the next day. People aren't even recognizing these issues that are happening out there. So another missed point of communication I felt in this most august report that came out 10 years ago, and I hope that there's some work on that. And then my final slide. So 7 generations is a concept with American Indians broadly. I hate to, American Indians call them a monolith. It is very regional and tribal specific in many cases. However, a lot have this idea that whatever you do now, you're supposed to be thinking 7 generations beyond what's going to happen, what's the outcome going to be. Similarly, something that happened 7 generations ago could be impacting right now, and the example that I'm about to give you does just that. So I often start out some questions for people beyond the ones I asked earlier. What do exterminate, remove, reserve, assimilate, terminate, and relocate have to do with each other? Do they have any meaning for you? Are they connected in any way? To American Indians and Alaska Natives, they instantly recognize these as federal policy periods. With the boarding schools, there's removal, Trail of Tears, and so you don't even have to say it twice or let them think instantly they know what these mean. But I doubt that most health professionals can really draw a line through these things. They represent structural, persistent, systemic, targeted anti-Indigenous racism, and it's so common that it's unseen by America. So I've just going to close with this 2-minute video. I'd like to tell you just 1 minute's worth about it. This was a structure that went up in 2017 in Minneapolis. It was sanctioned by the Walker Art Museum along with a non-Indigenous artist in California. When I'm talking about 7 generations ago, President Lincoln, who we, are all given the advice to revere for anti-slavery and so forth, ordered the largest extermination, or I'm missing the word, execution on U.S. soils, and it was against the Dakota Nation. And he wanted to hang 300 men and boys, but thought, what would Europe think? So he cut it down to 38 plus 2 later. So we actually call it the Dakota 38 plus 2. And sure enough, he ordered this hanging. A huge gallows was made, and they were killed to get the land from in Minnesota. So anyway, fast forward 7 generations, and this Walker Art Museum sanctioned a gallows to be replicated. So what I want you to get from these two things is the 7th generation. This is happening from what was going on, boarding schools and hangings and so forth, to today. And that it's also an exemplar for white privilege, in that I sent my daughter over there because we still have a house there, and she filmed this. And she said that the non-Indigenous people were walking their dogs by, they barely saw it, their kids were running up and down the steps on it and having fun and laughing. So if they saw it at all, they didn't see any problem with it. Meanwhile, the Indigenous people were on the sidewalk, watching in horror, being re-traumatized, and put up tons of signs. Nobody checked with the elders. Nobody checked with any of the many tribes in Minnesota or the urban peoples. They just did this thing. So I will leave this with you. I just want you to get out of those things. Think this happened 7 generations ago with Lincoln, and then this thing happened again. So we have to think forward 7 generations. So we can close with this, my part with this video.
Good afternoon. I'm Vincent Guilamo-Ramos, and I'd like to start by first just acknowledging Drs. Tahan and Moss for their wonderful presentations. It's an honor to be part of the panel. And also, I'd like to take a second to just thank the Institute for Nursing Leadership for the opportunity to speak with all of you today. I'm going to be sort of building on the conversation that we've been having. We started first with Hussein, Dr. Tahan, sharing a large overview of sort of DEI initiatives. And then we had a wonderful sort of example of American Indians by Dr. Moss, by Margaret. And so I'm going to talk about healthcare disparities. I'm going to try to weave together some of the ideas that we've been discussing as a panel and sort of set us up for a very rich discussion. So first, I want to take a step back and I want to share a little bit that may seem theoretical, but we're going to zoom right into the applied and say why it matters. But, you know, when I was in nursing school, a lot of what I was taught, and I've actually been in a number of different professional training programs, there was a tendency to focus on disparities as really being about individuals. There was a tendency to think about individual behavior or choices or somehow the reason why we have health disparities in the populations that we serve as nurses is reflective of what a person does. And I think what was less the case and what was something that I think more and more the nursing profession and other professions are endorsing is this idea that these disparities, that they really reflect sort of the individual in a broader context, and that context deals with what's often referred to as an ecology. An ecology that includes sort of the meso level, which is largely associated with the institutions that are outside of the individuals, things like the family, school, the community, the healthcare setting, et cetera. And then also the larger, broader macro level, which has to do with policies and sort of the larger society and sort of larger forces that shape, important outcomes. This system affects an individual over the course of their lifetime. And why is this important? This is important because if we think about sort of any disparity, and I'm going to illustrate in my next slide the case of COVID-19, but a lot of the differential outcomes are embedded not in solely individual behavior, but they actually are reflected in the social structures and arrangements that sort of permeate throughout the entire sort of three rings that you see on my slide. And a lot of these social arrangements, they're unequal, and they privilege certain groups or certain contexts, and they disadvantage certain groups in certain contexts, and they lead to there being disparate outcomes. A lot of the risks that people face in terms of the creation of a given health disparity is what we call exogenous, outside of the individual. And yet a lot of what we talk about is really about individual sort of decisions and behaviors. And so I just want to take a second to step back and just think about how many of the things that are part of sort of the fabric of our day-to-day life that may not be visible. I think Dr. Moss, Margaret did a great job at talking about invisibility. They're often not visible, but they actually create sort of outcomes for some that support health and well-being. And for others, there may be greater challenges and greater risks that lead to greater health disparities. Next slide. So as part of my time with you today, I'd like to create a bit of a personal connection. I always like when people sort of connect with me. So I'm hopeful that my sharing that for the past, I guess it's been over 20 years, I've worked in the Bronx, in New York City. The Bronx, in particular, the South Bronx, is the borough where I was born and where most of my research and clinical practice has been for more than 2 decades. I think most folks will know that since March of 2020, globally, we've had the novel coronavirus pandemic, and New York City at the start of the epidemic in the US was certainly the epicenter. And I think what's less known is if you look at New York City, you can see that the borough that had the most cases and deaths was actually the Bronx. And the Bronx, in particular the South Bronx, is a geographic area of vulnerability that is sort of heavily populated by Latino and African Americans. If you visit the Bronx, you'll find that overwhelmingly almost everyone is either Latino or African American. So taking some of the ideas that I sort of discussed in the first slide, I want to just kind of walk through a bit of a structural analysis and kind of talk about COVID-19 and explain why we have disparate outcomes. And so you can see on the slide that at the macro level, you can see that there's been sort of inconsistency in terms of leadership in our country regarding sort of mitigation strategies, clear direction. There's been sort of differences around health insurance coverage, who should be covered, who should not be covered, whether or not folks should be able to seek public entitlements, whether or not societal sentiment is set up in such a way or favors inclusion of all populations, particularly those that might be most at risk. One concrete example is if you think about individuals that are Latino and undocumented, a population that I work quite a bit with. Prior to COVID-19, there was a huge tension in our country regarding whether or not people who are undocumented, whether they had the right to be in the country, and whether or not the U.S. should adopt. This has been a very long-standing tension in our country, whether or not the U.S. should adopt a perspective that people who are undocumented should not be in the country. We know a lot of the recent attention that's been placed on the southern border between the United States and Mexico. I think what has been less discussed is that in a COVID context, a lot of the folks that at one time would have been deemed undocumented and therefore maybe not as welcome in our country were then reclassified as essential workers. These are the individuals that were responsible and are responsible for working in meat packing factories, or in New York City, for example, the example that I'm using here, they're the delivery boys or delivery persons. They're the folks who ensure that the groceries get stocked on the shelves. They work day in and day out to ensure that those of us that had sort of the privilege of being able to stay home and protect ourselves from COVID infection, that we could do that. Somebody needed to man those essential services. And so it's interesting at the macro level, that change in perception or societal sentiment meant that for some people, they would come into contact with more risk. At the meso level, these are our institutions. And so again, whether or not someone's able to access culturally appropriate services in their language, was there information? One of the big products that I'm working on now has to do with public housing in the South Bronx and COVID prevention. A lot of the guidelines that you hear that are, wonderful in terms of the scientific sort of basis for helping people to avoid COVID infection, they don't really work in a resource challenged setting. And so if you live in a 2-bedroom apartment with an intergenerational family with 6 or 7 or even more family members, it's a high density household. It may be difficult to isolate or quarantine if you rely on public transportation, and perhaps the city has reduced the number of public buses or trains that operate between the Bronx and New York City because there have been fewer riders. But that means that more people may be getting into those subway cars, and the people who are riding those subway cars who aren't able to stay home, as I mentioned, are oftentimes among our most vulnerable. And then at the micro level, if you think about sort of individuals who may have a high number of comorbidities, who may have sort of a more difficulty in terms of sort of managing their healthcare needs, whether it be their own sort of beliefs or sort of norms regarding healthcare access, or maybe it has to do with being underinsured or just not having insurance. I think that those kinds of factors, they help provide some richness to why we have the disparate outcomes in the Bronx. It's not just about people making bad decisions. It's about a structure at the micro and the meso and the macro levels that come together in a synergistic way that produce vulnerability and that create the disparities that we see in our country and our world today. Next slide. So right now, I'm working along with another nurse on a brand new randomized clinical trial. There's a large initiative called the RADIX initiative that is NIH's response. It's depending upon what you consider being included in RADx. It could be somewhere between $500 million up to $1 billion of investment. The RADx Up initiative is about $500 million, and it has a focus on helping communities that are vulnerable and underserved in increasing their testing for COVID and also adopting mitigation strategies at a community level, and then also preparing communities that would historically not necessarily be sort of easy in terms of dissemination of an effective vaccine, preparing that infrastructure, capacity, and some sustainable way of delivering the vaccine to them when in fact it does become available in the future. So Dr. Holly Hagan, who's a nurse epidemiologist, and myself, together as multiple principal investigators, we applied to RADx, and we developed this sort of concept, this idea that we could partner families from the South Bronx with nurses and community health workers that are indigenous to the community. And I think why I'm highlighting this project, we're just starting to move into the field in the next 4 to 6 weeks, but we have really thought about some principles that I think are important for addressing those micro, meso, and macro level influences that I was describing in my first 2 slides. The first is the idea of a novel healthcare delivery system. You know, nurses are the largest segment of the public health workforce, and I think in many ways, nurses represent an opportunity to move healthcare to where people are and to where the greatest need is. And so one of the things about our RADx product is that we have a model that actually supports nurses to go directly into households in the South Bronx to try to work with families on developing individualized mitigation strategies that are for that family. We know that the intervention is designed to be culturally appropriate and community engaged. We're working with members from the community that are part of the intervention team. They serve as community health workers that work alongside the nurses to come up with strategies that specifically fit into the South Bronx context. The kinds of interventions and the guidance that we're providing to the families really is rooted in sort of basic science and public health regarding how to protect oneself from COVID, but it takes into account the realities of their homes and their circumstances. What is it that a family can do when they actually have to take that elevator, or they have to get on that train, or they have to live in that household with 7 other people, and it may be difficult to isolate or quarantine. We also are dealing with issues of mistrust and misinformation. We're trying to also address issues of secondary sequelae that are coming not from COVID directly, but are actually stemming from some of the issues that have arisen and become more apparent. They may be pre-existing disparities in sort of psychosocial issues like sort of work, employment, issues regarding access to housing or housing instability, food instability, which has been a huge issue in our country right now. And so we're trying to use our community health worker, family nurse partnerships as a way of thinking through how we can support families, not only with sort of anticipatory guidance regarding if they become infected with COVID, but also with specific strategies that are psychosocial, that take into account context, and that also think about all levels of how we can reduce the disparity in the South Bronx in our country. Next slide. So my final slide is really to sort of take this example and try to make some broad statements about how to make it useful to nurses and to the workforce and to all of us that are participating, in this webinar, in this experience today. And so the first is recognition that nurses are the largest segment of the public health workforce. We know that. I think that, we are by far, healthcare doesn't happen without nurses in the US and also globally. I think the piece that is equally important is that our thinking as a particular segment of the workforce, I think that it would sort of serve us well if we continue in the upward trajectory that we've been sort of going and how we've been sort of thinking about what are the root causes of the disparities and how does inclusion, diversity, and equity help to reduce disparities by thinking about the entire system at the micro, the meso, and macro, the importance of nurse leadership, the importance of nurses being effective communicators and sort of not only serving an important sort of elected positions or boards or a national sort of projects, but also effectively communicating with the media. The importance of nurses thinking systemically about how the settings where we are working, how we can change them to be inclusive in the ways that Dr. Tahan mentioned. And then at the micro level, how we can examine our implicit bias and have a self-reflective practice that will help us to not only think about, sort of the kinds of things that I've talked about at the meso and macro level, but also within ourselves, how we can adjust what we do to better serve the people that we are committed to improving their health status. So I'm going to stop there and thank you for listening. Thank you.
I would like to thank the Academy for giving us an opportunity today to really talk about an important topic such as unseen diversity or DEI. This topic is so important, especially today more than ever, considering what we have been experiencing throughout the United States the past several months, but most importantly, most recently in the state of Texas. I'll give you one example why this subject is so important and our role in health policy or health professional leadership or nursing leadership, etc., why our roles are important in impacting a change, a social justice change in our society. Recently, the past couple of days, actually, as a matter of fact, Monday, at the direction of the governor's office, the Texas State Board of Social Work Examiners voted unanimously to eliminate disability, sexual orientation, and gender identity from the non-discrimination clause of the Code of Conduct. The board made the decision during a joint meeting on Monday with the Texas Behavioral Health Executive Council, which oversees regulatory agencies for professions related to mental health. So just imagine the impact this particular change in the state of Texas, and potentially probably other states may follow suit. What would that mean to caring for a social group that's disadvantaged, such as those with behavioral health issues? As well as this even infringes on rights, healthcare rights, and other rights of individuals, regardless of whether they needed behavioral health issues or not, such as the LGBTQ and other minority social groups. So today's presentation or today's conversation couldn't be any more important ever. So at this time, I would like to just conclude with some takeaways or some actions we can do as healthcare leaders before I turn over to the audience for question and answer with our panel. So first, we should understand diversity characteristics of our customers, regardless of who they are, whether they are patients we serve or the people we serve or the workforce we lead, or people in our personal network. We should really inspire confidence in our commitment to DEI. We should be mindful of our language and the choice of words. Also be mindful of our actions and our behaviors. Those reflect our context, our frame of reference, our perspective. Whether we mean it or not, the impact of those words and behaviors is really our context, how we approaching things. And we may demonstrate unconscious biases in that we may not be aware of, as the term implies. We must take the time to educate others about DEI, especially our team members at all levels in our organizations. We must make our commitment to DEI tangible. For example, we must allocate special funds to DEI projects and initiatives and to promoting health equity and health disparity. Managing health equities and health disparities. We should diversify our hiring processes and hiring pipeline. For example, we should be proactive in managing microaggression in our workplace environments. One effort to really manage and return the workforce and really take care of the talented workforce we have. We should also strengthen our policies. One example here, looking at our benefit packages or compensation benefit packages for our workforce, does such package exemplify or demonstrates DEI? Does our policies exemplify an environment of practice or a workplace environment that's welcoming to everyone, regardless of what social group they belong to? Does it welcome those with physical and functional ability limitations? For example, do we have environmental accommodations to accommodate those in need? And also, do we have special approaches to recognize and acknowledge those, for example, that are LGBTQ members? So those are only just a few examples of actions we can take immediately as leaders and health policy experts or influencers. But finally, and most importantly, I think our value or our ability to contribute to better population health outcomes. And in this case, I would say we should build diverse relationships with key community organizers, community advocates, and community leaders, because without them, we will not be able to be successful in improving the health disparities in the communities we serve. So thank you again, everybody, for today's opportunity to talk about DEI. And at this time, let's turn it over to our participants for any questions to me or the panel today. Thank you. So Dr. Moss, my first question is from the audience is to you. What specific questions should providers be asking their native patients, especially during intake, to ensure they are providing the correct care?
Thank you. I hope my microphone's on. I think it is. I would just say two things so simple. One is literally ask. Nobody asks anybody. Sorry, I'm trying to find my place here. How they want to identify. If the person seems somewhat diverse, people are really reticent to ask. And I'm saying it's okay to ask. In fact, you can ask if you can ask, if that makes you feel better, and say, how would you like me to identify you, as we move forward in your care? Literally just ask. No one ever asked me. And then secondly, very simple, is there anything that I need to know about your identifying to me that will impact your care, that you need for your care, that would be different out of the bell curve, you won't put it like that. And then just two more things. I often give a talk called Assume Trauma. When you have an American Indian or Alaska Native patient in front of you, assume trauma, whether it's historical trauma or this I just briefly touched on, for instance, the missing and murdered Indigenous women. Everybody, there's a lot of trauma, contemporaneous and historical. Just assume it and rule it out and work with that as you ask those questions. And the second one is to know that all American Indian and Alaska Natives, especially traditionally, come from high context cultures. So you can't know 574 different tribes and what they need, but you can know that if they're traditional, you can ask them that as well, that they're coming from a high context. So there might be things that they need that they can't even tell you, but you just know that there are these things behind whatever they're saying, as opposed to the usual dominant culture, low context, anything goes, new and improved, on to the next thing or whatever. That's not how many American Indians operate. So remembering that they're high context, so even if they don't tell you something, know there's probably something, and assume trauma, rule it out, and just ask them how would they like to identify, and what do they need to know, whatever they can tell you about helping them with their care.
Great, thank you. Dr. Moss, another follow-up question, and then we'll move on to Dr. Guilamo-Ramos. What resources are available to learn more about the Native population and their health needs? And it would be great if you can speak to educational as well as practice-related resources, academic and practice.
Sure, not to give a shameless plug, but I will. So my book is American Indian Health and Nursing, came out from Springer in 2015, and I wrote it specifically. You can't, again, write to 50 states or 574 tribes, but you can write to regions. So I wrote it in regions versus lifespan or, systems or whatever, because Alaska is different geopolitically than, Florida, and the plains are completely different than the Southwest and so forth. So I would encourage people to know which cultural area they are in the U.S., and there are 9. And then I added urban because, as I said, 78% are off reservation, 60% of American Indian Alaska Natives are urban based. So this book will guide you at least into the regions that are needed. And then at the end, there is, as I said, a couple of policy chapters. Also, you could go to IHS or IndianHealthService.gov to find out if there is a nearby Indian Health Service. And again, this is for federally recognized tribal members. But if nurses don't know, American Indians often cross borders. So if there isn't one in one state, they might go to the next. So just to know that there are these options out there. And then most states, if you just go to the state, executive area, you can find out whether there are some state programs for American Indians. And just to let your patients know also, there are in many states, at least for now, some provisions in the ACA that they can sign up anytime, and they might have some other breaks throughout. So, and one last thing, sorry. The thing that I just showed, the video that I just showed you, is actually in a new text that just came out called Health Equity in Nursing that I edited with Janice Phillips.
Okay, thank you. And the textbook you referenced, we'll see if we can make it available after the session on the Academy site. Dr. Guilamo-Ramos, I have a couple of questions for you as well. You addressed the many levels and systems that have a significant impact on health disparities, as well as the visible and invisible aspects of it. Where do you see the biggest gaps between those levels in our ability to eliminate what you really describe as health inequity?
Thank you for the question from the audience member, and thank you to Dr. Moss and Dr. Tahan for a wonderful panel. So I guess a simplified response would be to say that the greatest gap, the disparity, is really between the individual level and the meso and macro. I think too often we focus on individual behaviors and decision making, and we tend to conceptualize the disparity as somehow reflecting an action by an individual person. And I think what I was hoping to communicate in my comments was this idea that there are systems, and that these systems and processes that are not just at the individual level, but they actually are sort of ubiquitous to the entire context, that they shape who does well and who experiences greater challenges. And if we can try to understand that, and as nurses think about each of the levels and how we can be strategic in our interventions at all levels, we have a greater chance of reducing health disparities.
Thank you, and appreciate it. And as a follow-up question, how do we go beyond the term health disparity? And how can we focus closely on the structural barriers, especially like the ones that you identified in your presentation today?
Sure. So it's sort of related to the question that I was just answering, but I guess I would say that we need to think critically about the social arrangements and the processes that are reflected in our institutions, in our workplace, in society more broadly. And we need to critically examine our own positionality, who we are as nurses, how we relate to the populations that we serve, our motivations, for serving those particular populations, populations, some of the ways in which our practice may in fact be in alignment with the needs of the population, but also we need to be critical and really examine unconscious bias and think about ways in which who we are could in fact be getting in the way. And so that's tough. That's very difficult because it asks us to move beyond sort of our comfort zone and to really think about areas that require us to really have a lot of reflexivity in how we conceptualize what we see before us.
There are a couple more questions, and I think this one addresses research. So what advice do you have for researchers who are working to better integrate their research into the community? And maybe Dr. Moss, maybe you'll respond first, and then we'll turn it over to Dr. Guilamo-Ramos after.
Sure, and actually I just wrote a little piece on this in nursing research with a Robert Wood Johnson nurse faculty scholar. And unfortunately, I can't think of the name right off the bat, but anyway, it's conducting research in Indian country, something to that effect. And the first step is always build a relationship. You can't just drop in or just say, here's a survey or anything like that. You'll have to actually meet with the, if it's reservation-based, the tribe, the tribal council, get on the agenda. It's a whole thing. And you have to build a relationship. So for instance, in one of my first research projects in a Southwest tribe, I spent a year first coming and going, and my area is aging, so meeting with the elders and the senior center and so forth. So it takes time. It's often geographically diverse, and you have to have trust and relationships before you can even begin to think of doing research in any of these communities in Indian country.
So I think that's a great question. Just to add to what Dr. Moss was just offering us, I would say having a meaningful community engagement. And so I want to emphasize the word meaningful. For me, that means critically examining sort of, again, our positionality in terms of how we relate to the community, looking at the premise of the research question, our ideas about how the problem came to be, our methods for actually conducting the research, ensuring that at all levels of the research enterprise that we have a diverse and inclusive team. Really thinking about establishing a predictable relationship where community members understand what will happen, and then addressing directly issues of mistrust and really sort of straight on having that discussion with community members in a way that honors that there may be differences in terms of what each of our priorities are and how we want to work with one another.
Thank you. I would, from my perspective, I would add a lot of organizations, they're required to complete a community assessment, especially healthcare organizations for programs, healthcare services they provide. I would urge or encourage all of us, whether we are researchers or leaders or health policy experts, to really capitalize on the gaps we identify in those community assessments to then drive research practices as well as grant funds to focus on improvement in the areas of health disparities, structural, barriers to DEI, etc. So that area the opportunities are wide. So it would be great to really capitalize on that. At this time, we're at the end of our session, so I would like to wrap it up by thanking our expert speakers today and thanking our participants today for really raising great questions, and appreciate also the Academy for providing us with the opportunity to talk about a subject that's very important to all of us. It's timely, and it's really important for us to continue to focus on it. The work just begun. We have a long road, and we need to continue to progress. Thanks again, everybody, and would like to invite you to join our reflection session afterwards. So we look forward to continue this dialogue in the reflection rooms. Thank you again, and have a good evening, everybody. Bye.
Hello, I'm Kenya Beard, the Chair for Diversity and Inclusivity at the Academy. Our distinguished speakers and facilitators, thank you for your expertise, your openness, and willingness to share. And to our audience members, thank you for your presence and insightful questions. From the beginning of the pandemic, it was apparent to us in New York that COVID-19 was impacting racialized groups at disproportionately higher rates. As chair of the Academy's Diversity and Inclusivity Committee, I joined my colleagues at our April meeting to mourn our losses, express our frustrations, and to better understand the ways in which the deeply rooted racial injustices contribute to these inequities. When George Floyd was killed by police officers over Memorial Day weekend, shortly after the murder of Ahmaud Arbery in February and police shooting of Breonna Taylor in March, it seemed impossible and irrelevant for the committee to focus on anything besides the tenacious ways that racism presents in all aspects of our society. Throughout the summer, President Eileen Sullivan Marks released statements and a fan mail message calling on the fellowship to join together in collective reflection and action against racism within our organization. The D&I committee knew we needed to do more. We knew we needed to act in a forward-thinking and public way to begin the process for healing and change. The committee agreed that hosting this critical conversation was essential and would provide a platform where we could acknowledge the pain caused by structural racism, the normalization and legitimization of practices that advantage some while harming racialized groups, and to find solutions that will make a sustainable impact. As providers, false beliefs and assumptions can cause irrevocable damage to the individuals we pledge to do no harm to. As educators, we influence the next generation of caregivers. Therefore, it is our duty as nurses and leaders to process and understand what we learned today and use it not to shame or blame each other, rather to move forward in a way that allows us to come together to dismantle the structures that impede health equity within our individual organizations and throughout our collective systems. On behalf of the D&I committee, we are so incredibly grateful to the board, in particular, our board liaison, Dr. Deborah Barksdale, the INL, and the Robert Wood Johnson Foundation for their support in making this courageous discourse possible. I look forward to seeing the progress we make moving forward, and I'm sure that at a minimum, this event will serve as a catalyst for a more diverse, inclusive, equitable, and socially just academy. Thank you.
Hello, I'm Julie Fairman, and I'm honored to be the chair of the Institute for Nursing Leadership's Advisory Board. This has been an incredible program. I'd like to thank each of you and also the speakers and facilitators, as well as you, the engaged audience, who helped to make this INL critical conversation event successful and give us the foundation to have an impact in our work and our lives. As a historian of nursing, I have seen the long history of racism and unequal treatment in our health systems, our education and academic systems, and our health policy. It is my sincere hope that this critical conversation, our in-depth dialogues, and the upcoming reflection rooms will create the necessary call for each of us to put in the hard work, to change policies and practices that promote bias, and ultimately achieve equitable care in all entities. Before we break out into the reflection rooms moderated by members of the Diversity and Inclusivity Committee, as chair of the INL National Advisory Council, I would be remiss not to thank the co-chair of the INL, Jenny Chin Hansen, and our planning committee members, Dr. Bobby Berkowitz, chair, and Hussein Tahan, co-chair, as well as Kupiri Ackerman-Barger, Guardia Bannister, Jackie Dunbar-Jacob, Janie Heath, LaRon Nelson, and Adriana Perez. I would also like to thank my colleagues on the INL National Advisory Council and the Academy's Diversity and Inclusivity Committee members for their support, which helped to create such a dynamic program of impact. I must also thank the Robert Wood Johnson Foundation for their generous partnership and support of this crucial event. Finally, I would like to recognize and express appreciation to Karen Drinkard, our board liaison for the INL, and a longtime INL committee member and former co-chair. Now, please check into the reflection room session where we will engage in real time with each other to discuss the day's conversations and unpack their ramifications. This is a time to pause. Ask the questions that will continue and encourage us to think differently and help us build in all of our communities a culture of civility, diversity, inclusivity, and equity. Thank you again for joining us, and I look forward to the progress we can achieve together.